Okay, so let's once again review the signs and symptoms. This time I'm specifically talking about emphysema. If you'll note in the picture on the right, this gentleman has a lot of the physical characteristics that you'll typically see with somebody who has emphysema. Some things you'll see is shortness of breath, usually of slower onset, wheezing or decreased breath sounds, a cough that'll produce a small amount of colorless sputum. Usually these patients will have a decreased fat mass. They'll be barrel-chested, as you can see on the picture on the right. Also be breathing through pursed lips in a tripod position using accessory muscles, and those are also all exhibited on the picture on the right. Signs and symptoms of somebody with chronic bronchitis, a lot of it's similar. It's going to be a shortness of breath, wheezing and diminished lung sounds, and you can also hear some coarse rhonchi. These patients tend to be a little bit more obese than the patients with emphysema. They also may have signs of a right-sided heart failure, accessory muscle use, and a frequent cough. Some signs and symptoms of chronic asthma are short of breath, and this can be rapid onset. This will have a wheezing and some diminished lung sounds, also the accessory muscle use and tachycardia. Now, how does CPAP help somebody with COPD? Well, this will also decrease the inspiratory effort. It'll keep inflamed airways open during exhalation. It also helps gas trapping. We'll talk a little bit about that. As you see on the picture on the right is a chart of your normal inspiration. You can see in the red block with the green filling in, you'll see what it looks like when you take a deep breath in. As you let your breath out, the dotted line will show normally what will happen. With these solid lines, you'll see at the end of your expiration, the beginning of the next expiration, that with a normal or a patient who has an obstructive disease, that they don't have all of their air all the way out before they start breathing in their next inspiration. And then this kind of gets worse with every breath, and this gas trapping can actually cause a lot of problems for people with COPD. So as we talked about earlier, with a normal inspiration, you can see how the pleura has to pull apart to create that negative pressure to bring air in. We're talking about somebody with COPD. This is how the gas trapping happens. At the end of the expiration, when there's a resistance, you can see that gas can be trapped in the alveoli at the end of expiration. This is due to the obstruction, whether it be chronic bronchitis or some other type of problem, and this applies an end positive pressure inside the alveoli. So now, with this gas trapping, you'll see that in order to take a breath next time, where normally it would have to be a negative 7 atmospheric pressure to get air into the lungs, to overcome the gas trapping, you actually have to have, in this diagram, a negative 13 atmospheric pressure just to get the same amount of air inside. They're doing a whole lot more work in order to get the same amount of air in. By applying CPAP, what actually happens is the positive pressure throughout the whole respiratory cycle reduces the negative pressure requirement of the pleura by shunting open the resistance. It's a lot easier to help overcome the pressure gradients. And you can see from the example here, you actually get a lot more air into the alveoli just by applying the CPAP. One other thing we'll quick touch on is pneumonia. Pneumonias can be a bacterial or viral infections. Some things that we may see, especially in nursing homes or people on tube feed, you may see an aspiration pneumonia, and you'll see that these can be localized to just certain portions of the lungs. Some signs and symptoms of pneumonia include shortness of breath, fever, fatigue. I've said fever is another big one that you can use to differentiate between pneumonia and some other respiratory diseases. Accessory muscle use, once again, another big one is altered mental status. This is caused by the infection. These patients you may actually see coughing up a colored sputum, and you can see from the color chart on the right, there are wide ranges of different colored sputum that people with pneumonia may exhibit. These patients may also have some wheezing, some rales, or rhonchi. Some risks to consider, risk for patients getting pneumonia include being exposed to crowded institutions, being exposed to different types of animals. Also, people that work on air conditioning or water systems are at increased risk for pneumonia. Well, what does help the CPAP help the pneumonia is it just reduces the effort of breathing and is help keeping the airway open, much as it does in the other disease processes. But really, the big benefit for CPAP, not only for pneumonia but for all the rest of the things that we've been talking about, is it helps keep patients off of ventilators. Once patients are on ventilators, there's a lot of complications involved, and it's very difficult to get people off. Some complications include ventilator-induced lung injuries, oxygen toxicity, pneumonia, the auto PEEP, as we kind of touched on before, and difficulty getting patients off ventilators. One of the doctors that I listen to often has been quoted saying that if you actually intubate a patient with CHF, you failed in his mind. The whole goal of our treatment in somebody with CHF is just to keep them off the ventilator altogether. One study showed actually that 20% of people that get put on a ventilator require a prolonged weaning off of the ventilator. So now that we've talked about times where CPAP is helpful, let's touch on some things where CPAP is not helpful. Somebody in respiratory arrest is not helpful to put them on CPAP. If they're not breathing on their own, CPAP is not going to be able to help them. Somebody with chest trauma or possible pneumothorax. Somebody with a tracheostomy. If you put them on a CPAP, remember as we talked earlier with the upper airway anatomy, that they're all connected, and if they have a pressure in the top of their airway, it's just going to, the hole in their throat is going to keep them from having a pressure throughout their entire airway. Somebody who is vomiting or an upper GI bleed, CPAP is not helpful because it increases the risk of aspiration. Somebody with recent facial or cranial surgery will prevent you from getting a good seal on the mask, and if you don't have a good seal on the mask, the CPAP is not going to work for you. Also, somebody with esophageal varices or esophageal surgery, it's another contraindication, just because in case there's any kind of type of bleeding, it's going to cause a big aspiration risk. Also, somebody who had a recent stomach surgery where there was some kind of stomach stapling, there's a small risk of actually ripping the staples. Real quick, we're going to go over the BLS protocol. This is for Pennsylvania, the BLS state protocol. The criteria for getting into it is a shortness of breath, and then any condition which produces shortness of breath from bronchospasm, that it could respond to bronchodilators. These conditions are generally associated with wheezing, and they go down to name some of the things that we have just talked about. Conditions which produce shortness of breath without bronchospasm that do not respond to bronchodilators, and they're not associated with wheezing, and they list a CHF as one of those. Another criteria could be a possible pulmonary embolism, and there are no exclusion criteria to entering the respiratory distress, respiratory failure protocol. In order to be able to use some of these things, you have to have an EMT that has completed the bronchodilator module through the EMT curriculum. That's to assist using an albuterol inhaler, or they had to have some kind of con ed to assist with the bronchodilator. What we're talking about here, the system requirement is CPAP can only be used by an EMT that has completed the Department of Health BLS CPAP training, which is what you're going through right now. And then the C is another thing that's needed in order to be able to use CPAP for a BLS provider. They also require that you use a pulse oximeter, and that your EMS medical director is overseeing the CPAP training. For all patients, you're going to want to apply high concentration oxygen, and then if you need to, somebody who has respiratory depression or isn't breathing, you want to assist respiration with bag valve mask. You want to monitor pulse oximetry, and if needed, you're going to apply the CPAP. You're going to apply a CPAP to an adult patient if there's no contraindications, which we've talked about, and they have at least 2 of the following after having applied a high flow oxygen. One of the 2 is a pulse ox of less than 90%. You're going to have a respiratory rate of greater than 25 breaths per minute, or the use of an accessory muscle during respiration. Any 2 of those 3 will meet the criteria for you to place the CPAP on the patient. If the CPAP is applied, you're going to place the CPAP on the patient, and you're going to titrate the pressure on the manometer till they're improved or until you hit a maximum of 10 centimeters of water pressure. You're going to remove CPAP if respiratory status deteriorates, and then assist with BVMs if needed. This part of the protocol goes on to say what the CPAP contraindications are, and we'll review them real quick. Anybody who has an altered mental status or can't follow commands, that's a contraindication. Patients less than 14 years old, unless you're ordered by a command physician. Any patient who has a respiratory rate of less than 10, or if they're apneic, or if you believe they're unable to maintain an open airway, do not place the CPAP on them. Any patient with a chest trauma or suspected of having a pneumothorax, if they have a tracheostomy or active bleeding, or any kind of GI bleeding, you do not want to place a CPAP on these patients. Now, some things to note through the protocol, that if CPAP is used, you're going to want to remember that your oxygen supply is going to be depleted rapidly. So you just want to keep an eye on your oxygen supply to make sure that your oxygen isn't depleted. And a lot of the systems out there being used are going to need a certain pressure behind the oxygen, so as you get lower on your tank, you want to keep a real good eye on it to make sure that you don't get depleted all the way. You want to ensure that ALS has been requested if available, and then also advise your ALS crew that CPAP is being used. You want to notify your hospital that the CPAP is being used, because they're going to need to call respiratory therapy down into the emergency department to be able to get their machines prepared to put them on the CPAP. You want to watch for gastric distension, and then that could be a sign that vomiting could occur. They note that CPAP can be used on a patient with a DNR. That means somebody that has a do not resuscitate order. They still can have CPAP applied. Vital signs, including your pulse ox, need to be obtained and documented in your chart every 5 minutes. Now we're going to go a quick video from the manufacturer of the FlowSafe CPAP device. That's the device that we've decided to use here at Upper Saucon Ambulance. It's going to show how to apply these masks. One other thing we want to note during this presentation is that for specific to our organization is that we're going to have a separate oxygen bag for the CPAP. That's where we're going to keep all the CPAP circuits, and we just want to note that with the tank that is in this separate oxygen bag, we need to keep it at 2,000 psi at all times. Anytime it's used at all, even if it's not all the way empty, please replace it so it's kept at 2,000 psi so we can be ready to use it all the time. Also, the regulator that's going to be with this oxygen bag is a special regulator that will go up to 25 liters per minute, so this must stay with the CPAP. So I'll go over the video here real quick.
Okay, this is going to be a slow, methodical application of the FlowSafe disposable CPAP device. It's really never a good idea to run in and strap something onto somebody's face. Remember, they're going to be hypoxic, they're going to be scared. You've known them all for about 2 or 3 minutes. They've never seen it before. One of the best descriptions sometimes that people use is to describe using CPAP is like sticking your head out the window of a car while it's going down the road, that blowing into the face. And most people have seen that or have done that themselves and can understand the analogy of that or the comparison. So what I normally like to do is I like to ask the patient, can you go ahead and hold the mask for me? I like the patient to stay in control. They have some say of what's happening. Makes them feel like they're involved. So I let them kind of hold on to the mask. Now I'm going to start out on a rate of the heart failure patient. The flow is going to be at 15 liters per minute or 5 centimeters of water pressure. That may be the right place, it may not, because we're going to have to titrate based on how the patient performs. You notice I don't have my hand over the end. Again, that could cause an increase in pressure. Some patients will say they'll start to pull it away. They get a little bit of anxiety, a little bit of claustrophobia. That's okay. Let them stay in charge of it. Let them do it. In the meantime, you're starting to exert some pressure where you're going to take control of it, but let them stay in control. If they get too upset, I've actually had patients throw up into their mask, because we're going to try to avoid that. As they're doing that, you can have yourself or you could have your partner, and a lot of times it can be a second rescuer, will come in and attach the straps. The strapping system that we have here, we have the little pins on the mask, and they just slide right over the top, and you've got one on the top and one on the bottom for each one. And if you remember, compliance has to do also with comfort and getting this mask on. Now I have half the straps. Now you're going to have a second rescuer, and some of you may even ride with a third and fourth rescuer. Make this part easier. You got to slide this around. It's going to go onto the crown of their head, and we're going to bring this around. And as you can see, it comes around to the other side. My patient's going to be very cooperative here, and he's going to help me a little bit. And we're going to come on, and I can have him move his hand. Move this finger, please. And I'm going to get that strap on, trying not to pull his hair. And then I'm going to get that strap on, okay? Now, these CPAP devices come with a variety of masks. You can have a smaller one, a medium one, and a large one. And it's okay to stop and change masks, if you find that this is not fitting correctly. You can ask him, how comfortable is that? How does that feel to you? He may shake his head, okay? The other part of this, you may have to be popping these masks off to give nitro. You may be incorporating capnography into these. This is all fine. Some of these masks can even be used to put breathing treatments through. For a patient you may want to give a bronchodilator therapy would be okay. Again, now you're assessing the patient. I kind of like to keep my hand on their shoulder. I like to talk to them. Breathe with it. This is going to help you breathe. This is going to make it easier for you. Try to stay away from negative comments. They're already in probably the worst state that they're having in a while. So we're going to try to stay positive all the way through this. If he's still having some trouble with it, turn your flow up. Give him the air a little bit faster. Make it to where see if we can meet that. But if he's fine with the 5, and we're getting some compliance with it, and the mask is comfortable with him, then we're doing fine. See how is the saturation, is it getting better? Is his work of breathing to you, does it appear to be better? He's not working as hard. It's not as difficult as it was. Again, I would continue to talk with him. Whoever gets that rapport with the patient should stay with that patient all the way to the hospital. They start having a good working relationship on how things are working. If the flow is not working, bump it up, go up to 20 liters, get 7.5. Now, these numbers may change if you end up in your protocols that you're doing this with chronic lung patients, your asthmatic patients. You may start and titrate from lower numbers, such as 2.5. Again, follow your protocol and what you're allowed to do. At this point, I'm going to monitor him all the way. He's probably going to have an IV started. The thing that you got to remember is that most of you will be using D cylinders or E cylinders. The D cylinder, which is common in the system that I'm using, if you're running this at 15 liters, you're going to get about 1 minute for every 100 that is in your tank. So as part of the preparation, we actually carry a second tank with a regulator on and try to start every call with a minimum of 2,000 in your tank. That way I know I have 20 minutes. I work in an urban EMS system. Short transport time is not a problem for us. But if you work in a community that's longer transport times, having a second, third bottle, second regulator to change out would be very valuable. Okay, once you arrive at the emergency department, you're going to find that you're able to leave the disposable CPAP device that you spent a significant amount of time getting fit and making the patient comfortable can stay on the patient. We did a survey of the emergency departments in our county and found that most hospitals only had about 3 or 4 CPAP devices, many of which were in service. So a lot of them for sleep apnea or for whatever patients that needed it. What were they going to use in the emergency room? Now we can leave our device behind. Another area that is being noticed is during our recent pandemic flu, the H1N1, it was predicted our community was going to need 35,000 ventilators. We know we only have about 1,000. Well, a lot of those folks may have been able to be sustained using the CPAP device, and the disposable would be the ideal, especially in an infectious disease environment. So there's no way we're going to be able to meet the demand of ventilators, but through a disposable device such as the FlowSafe, we'd be much better chance of meet that demand. As most of you know, the CPAP device that we have comes out with a mask that's more of a disposable, smaller version. But the new mask that's coming out, as you see, will have some innovative features that the other mask doesn't have. It's going to have a more comfortable, flexible strapping system, and it also has the supports on the forehead to take the pressure off of the nose. One of the more areas that most people complain is where the comfort issues are. As a lot of people realize that in respiratory, the adapters, everything is pretty much the 22 milliliters or 15 millimeter adapters, so the valve is going to plug directly into the mask, as you can see. The flow rates are still the same. We're still going to do 15, 20, and 25 to get our 5, 12, 7.5, and 10 centimeters a peep, but you'll notice we'll have a much more comfortable mask. As we can demonstrate here, the straps are already on, they're Velcroed, is we can actually have the patient hold it, as we do in most of our CPAP administrations, let them hold it, only this mask can be brought over to the top of their head and much easier to put on, and then can be adjusted just like any type of Velcro to get the better fit. One of the advantages that this mask has over other masks is one of the things that we want to do to patients that are on CPAP is to be able to give them nitro. And every time I take the CPAP mask off, I lose the pressure and the value of the therapy. In this case, I'm able to take the mask, I can raise it up very quickly because of the strap stretches, give them the nitro, and put the strap back down. This is an advantage over most other masks that we're seeing out on the market.
Okay, so let's go over real quick when you can remove a CPAP. Anytime you notice any kind of vomiting or bleeding, immediately take the CPAP off. Anytime after a while you've tried but you can't get compliance, it seems like it's just causing the patient more stress and anxiety, it's okay to remove the CPAP. Anytime that you notice the patient's on the CPAP and their condition is deteriorating, at the direction of medical command, and then you want to leave the patient on the CPAP on your way into the hospital. Only take off when respiratory therapy is ready with their machine and ready to place the CPAP on the patient. What do you need to do for documentation? Well, right now here at Upper Saucon, our CPAP circuit can be replaced by the EMS Council. So there's certain information that the QA officers are going to need in order to get them replaced, and really as good practice should be in your documentation anyway. These include the inclusion criteria, what criteria exactly it was that you used to include the patient into the protocol so that you actually placed them on the CPAP. And remember, from the protocol that we reviewed, there are 3 inclusion criteria, and they just need 2 of the 3, and that was a SpO2 of less than 94 with them already being on oxygen, a respiratory rate of greater than 25, or any kind of retractions or accessory muscle use. Any suspected indication, do you want to state whether you thought the patient was having congestive heart failure, COPD, pneumonia, or if you're just not sure, you can put that you were unsure of what the suspected disease process was. You want to put what the patient's condition on arrival at the hospital was, and the options are improved, the same, or worse, and you're usually documenting that on most patients anyway. You want to include any kind of difficulties or complications involved with the use of the CPAP. Also want to put that the CPAP was discontinued if it was discontinued prior to ED arrival, and then if there was an ALS intercept or if you had to use an ALS unit, just document what that unit was. If there's any kind of questions that you have about the use of CPAP or any of the diseases in general, you can talk to any of the people here at Upper Saucon. Any of the officers would be glad to give you a hand. Before the end of the to get you signed off completely, there is a small test and a couple of questions in order for you to ask, and also there's any type of practice that you'd want to use. We have some spare CPAP devices that you can use for practice, and then when you're ready, just come and see the training officer or any of the other officers of the Corps, and we'll just go over real quick and demonstrate that you know how to use the CPAP device so we can get you signed off in order to use it on the ambulance.